Good evening, everybody. On behalf of the President of Urological Society of India, Dr. Sanjay Kulkarni, who is on his way for a meeting abroad, is on his way for the BOSS meeting. I am doing the pleasantries and greetings from the President as well as the entire Council of USI. We are also delighted to have Dr. Sabnis with us. And he engaged us, as rightly put, that he was playing the night watchman and, he held the innings together till our star came in. And our star is actually a BC Roy awardee that, I must, because that is the highest award a medical man and a medical teacher can aspire for. And he richly deserved it. And then we are all proud of Murthy sir for not only this, but for his gentle ways and his commitment to the cause of urological education. Recently, we enjoyed not only his hospitality, but also a lot of academics in Hyderabad when he actually helped us to organize the mock exam. It was a model exam, I would, for a change. It was not a mock exam, it was a model exam, and he made it possible. Thank you very much, sir. And without much ado, once again, I would thank the Indian School of Urology for choosing a real acharya to teach us the shastras, which are used which are used to manage lower urinary tract maladies. With these few words, I over to Dr. Janani Sharma ji for the proceedings of the evening. Thank you very much and namaste to everyone.
Thank you,
so
Prabhu.
you have very rightly said. We had Sabnis sir and now we are having Murthy sir. So it is like having Sachin Tendulkar and Virat Kohli both at the same time playing on a very difficult pitch, but making batting looking very easy. So I think I would straight away hand it over to Murthy sir to go ahead with his talk.
Yeah, this is okay. Thank you, Dr. Sharma. And really, it's very nice to see all the very dynamic the faculty. The council. And really, it is tempting me to come back to academics looking at these people. Okay, thank you very much at the beginning for giving me this opportunity. I really enjoyed. I also learned some points. Okay, are you able to see my slide?
Yes, sir.
Yes, sir.
Voice?
Yes.
Able to hear?
Yes, very clear, very clear.
So I will straight away go into the topic. So let us learn the basic tenets of endourology for the students. You should know fully the instrument you are going to use. This is very important. Check the instrument function before application because some bolts and nuts may be loose. When you put into the bladder, the beak or some nut will get loose and fall into the bladder. That happened to us earlier. When we were doing TURP, the Teflon, the Evacuator, the Teflon beak got detached and fell into the bladder. That is the thing. So you should always check the instrument function before application. Never force through the passage. As you know, the urinary passages are narrow. They are very delicate. So don't force it. You should go effortlessly. Sometimes you need to have a gentle pressure to get into this. Once they are injured, the morbidity will be there. So one should be very careful to introduce these instruments. And delicate handling of the instruments and tissues as well is important. So coming to the cystoscope, which we use day in and day out, knowing the pathology of the urethra as well as the bladder, it was actually invented way back in 1878, whereby Max Nitsch is the one who first demonstrated the working cystoscope, the modern cystoscope, which he had created in collaboration with a instrument maker in Vienna, is Joseph Later. Coming to the flexible scopes, which are now being used very frequently in endourology. This goes to Japanese people, Tushida and Sugawara, way back in 1973, which they use of the flexible cystourethoscopes. So before we go into the actual this thing, we have to know about the urinary tract. It is very important to know especially the male urethra. This is the male urethra. You see this. There's a pendulous urethra, and After that, you can see the bulbar urethra. Remember, bulbar urethra is a cul-de-sac. From there, the membranous and prostatic urethra goes straight up into the bladder. So when you straighten the penis, almost you can go up to the cul-de-sac. That is where people do mistakes. They injure the bulbar urethra because a cul-de-sac just come back a little and you should look upward into the membranous and as well as the prostatic urethra. So at the membranous urethra, you know, there is a sphincter. Especially when you are doing cystoscope in local anesthesia, the sphincter may be in spasm because the patient is apprehensive. So it is very important to gently apply with the big pressure and get into the bladder. That is where the amateur or the residents make false passages, the bulbomembranous junction. So one should be very careful at that area. Then coming to the female urethra, you know, this is short, about 4 centimeters in adults, and this is very delicate. Making false passages or injury is very common. So one should calibrate before you introduce any sort of scopes into the female urethra. So the instrument makers, of course, you know, these are the companies, the Carl Sturge, Richard Wolf, and ACMI Olympus. Of course, almost all of us, our generation, are trained on Carl Sturge. So most of the time we will be dealing with them. And some of the instruments also from Richard Wolf, especially the ureterorhinoscopes, which many people favored Richard Wolf. And ACMI, of course, one of our professors in Bangalore, Joseph Anthony, he was using his American board certified member, he was using this ACMI, the pillion rod working element and all those things. And Olympus of late has come into the market extensively. Their scope was bigger. And this is mainly we are doing the bipolar resection of the prostate. That is where we are getting the resectoscope of the Olympus and cystoscopes, and also the flexible cystoscope of Olympus. So these are the main companies which are distributing this equipment. Coming to the cystoscope, of course, day in and day out we are using, there are 3 parts here. There's a lens, there's a bridge, and which connects to the sheath. And this is, of course, you know, the indications are mainly to know the urethral pathology as well as bladder pathology. Urethral strictures or any growth, or sometimes you see the bladder growth or bladder stones. And also we can use therapeutically in some of the cases biopsies, multiple biopsies as a diagnostic pathology, which you want. The cystoscope is extensively used. It is said that a resident should do at least 500 cystoscopies before you go for resection, I mean a resectoscope. But nowadays, due to availability of good imaging, we are not doing that many cystoscopies. When you are doing a cystoscopy, definitely there should be something in your mind, what exactly you are going to see. Just like that, not. See, many people do for lower urinary tract symptoms, but you should not, should have an idea that what exactly you are expecting in the urethra or in the bladder. So there are a number of sizes of the cystoscopes. They are calibrated or written in the French scale, that is the French scale. And you can see the smallest cystourethroScope is the 17 French. This is what usually given to a resident so that the injuries will be less when using this. And this has got an obturator, there is a color coding, and also the size will be mentioned there. And also there is an outlet and an inlet. And this is the shaft where there is a gradations. That means there is a markings engraved on this 1 centimeter apart, about 13. And the last 10 centimeters, you see there are no gradings. And you can see a bulbous smooth end of the cystoscope. So that we can straight away, without even a trocar, obturator, we can introduce into the urethra this kind of scopes. So all the cystoscope sheath has got a bulbous end. And these are the color coding. You can see that yellow is 17, green is 19, this is 20. And of course, there is one missing here. The blue color is 22, and another is white. That is 25 French cystoscopic sheath, because these are used in different ways whenever we want to introduce bigger instruments to the cystoscopic sheath. If you look at that, this is the 17 French. That is where this is marked. This is the size of the sheath. The French, you know, the one thing which I learned even till I remember, 1 French is equal to 1/3 of a millimeter in diameter. And 1 French is equal to 1 millimeter in circumference, 2 pi r. Even though the cystoscope cross section is not a oval, but we use is not a circular, it is more of an oval. We use this. So in circumference, suppose 17 French is 17 millimeter circumference. That is what. If a 30 French Foley's catheter is there, the diameter is 10 millimeters. That means 1 French is equivalent to 1/3. So 30 French is, this is 10 millimeters. That is 1 centimeter is the diameter. And if you take the circumference, it is 30 millimeters. That is what I remember still. And you can also see there is another circle which encloses a 5 French. That means a 5 French catheter can be passed here. Of course, this is one of the things is inlet and outlet where the irrigation goes into this. And when you introduce the obturator, you can see the 0 here and also 0 mark here. That means the coupling, when you are locking it, this should couple with 0 so that we can close it. And you can see another 19 French cystoscopic sheath, which is color coded with the green. And you can see the 19 number here, marked here. And also there are 2 circuits here, 4 and 4. That means when you use an Albaran sheath or a 2 channel bridge, you can always introduce 2 4 French size catheters. But there is another circle which is encircling here 5 French. That means you can only introduce 1 5 French catheter. That is what. Again, you can see the 0 mark. So all cystoscopic sheaths are the same. There will be some difference in the vesicle end. If you look at this, this is the one vesicle end where there is a bulbous smooth, so that we can introduce without traumatizing the external meatus or navicular fossa into the urethra. And when you compare it with a urethrotomy, see this, here it is blunt. There is no bulbous end. And so this should be introduced with a trocar, with the obturator. And if you see that there are no markings here, here you can see the markings from the beginning, 1 centimeter apart. The idea is the marking starts only after 10 centimeters. This is mainly to measure the prostatic urethra. That is what we do, and prostatic urethral length, so that we can always assess the size of the prostate roughly. When you look at the ventral end, this is the 17 French, which mainly used for female cystoscopy. You can see a diamond shape, this one for irrigation, and short irrigating or fenestrated end. If you look at the 19 sheath or further other sheath, the fenestrated portion is very long, maybe 2.5 to 3 centimeters here. So here, these things are used for female cystoscopy. You know that female cystoscopy is very sharp. When you introduce it, most fluid will be escaped if you introduce this. So it won't distend the female urethra and very difficult to see. But if you use this, you can introduce, and this flow will distend the female urethra under vision. You can see while going inside and also while coming inside. So that is the difference here. And you can see the 25 French cystoscopic sheath. You see that there's a markings up to here, and this is the obturator. When you see this obturator, when the obturator, the difference is in 17 French obturator, the cycle end has no groove, but other obturators has got a groove. This is for the ingress of effluent, I mean the water, into the scope, so that we know that it is safely inside the bladder. So in a female, of course, as I said, when you introduce the scope, a lot of irrigant will be escaped. So the urethra cannot be distended. There is one adapter. This is the Nichols adapter, which you can press against the urethra, female urethra, and you can introduce safely and inspect the urethra in the females. That is the Nichols adapter. Usually, most of the time, we don't have this one, only a textbook reading, but I don't have this Nichols adapter. And coming to the bridges, there's a single channel bridge. This is the channel for the lens. This is channel for the, accessories. There is a nipple here, and also the locking system, and there will be zero mark here that is coupled with cystoscopic sheath, and there is a single channel and also double channel is available. So that two catheters can be passed at a time. And there is an Albaran lever. This is, of course, nobody nowadays using. It is also there in the armamentarium. This is mainly catheter deflecting mechanism. This can be accommodated in only 19 cystoscopic sheath and further. And you can see here, there's a knob here and a pointer. This is the one which deflect the catheter system. This is mainly to facilitate cannulation of the ureteric orifices. But nowadays, we don't cannulate the ureter directly with the ureteric catheter, because some of the catheters are traumatic. We always put a guide wire first, and then over that we introduce the ureteric catheter, because the ureteric catheter ends are sharp. They may produce false passages. So nowadays, usually, but sometimes you require this deflecting mechanism, which you can deflect it up to 90 degrees. And this is the deflecting mechanism, this is the knob, and the pointer shows you how much deflection is taking place. Coming to the rod lens system, that is what the Hopkins 2 systems we are using. The commonly used are 30-degree lens and 0-degree. There is a color code in this. 0-degree is the green, and 30 is the red shoulder here. And this is the lamp post where you can connect the light cable. And also this is the eyepiece, or the ocular funnel, they call it, ocular window. And the rod lens system, of course, the 0 and 30 mostly use. 0 for urethroscopy to know the urethral pathology, and 30, of course, not only urethra, the entire bladder also can be scanned with 30 degrees. And earlier we used to have the 70. The 70 is actually meant for a retrograde catheterization, that is passing the ureteric catheter actually for cystoscopy. And there is also 120 retrograde vision telescope and 12-degree, which usually we don't use these things. So if you go to the rod lens system, in the conventional technique, usually the lenses are separated by air spaces. And this is very difficult also to manufacture, because the lens should displace most of the time. And also the air will take away all the light. The light will get refraction and mostly absorbed here. That's why the images are very poor quality. So this is revised by the Hopkins, who was awarded Nobel Prize for this. And these air spaces rods are replaced by glass rods, which are very fine and polished glass rods. The refraction, the loss of light by refraction is very less. And these rods are separated by air lenses. And this is also very easy to construct by the company. The design is mainly the computer, and it is easy to put these rods. And not only the resolution, the image is also easy. You can see how the vision will take place here. The 0 degree has got a forward vision, and 30 has got a forward oblique, and 70, of course, lateral as well as downward vision. These are the common lenses which we use. This is the structure of the lens. You can see that these are the rod lenses. There is objective lens there, and this is the eyepiece, and this is the light post from which there is a fiber optic bundle which runs right up to the end of the objective lens. That is the one which carries the light. These are the various, projecting the lenses with the color code. 0 degree is white, as I said, and 12 is black, and also 30 is red, and 70 is white, yellow. So this is how, and interestingly, the present day lenses are autoclavable. That is one thing. The conventional ones are not, but this is autoclavable for sterilization. There is an integrated universal cystoscope where the lens, the bridge, and everything is integrated in one piece. The advantage is you can use for multi-purpose, for biopsies, for removing the foreign bodies, because it's got a 7 French channel, a bigger channel, and a slender scope. So this can be used for many other purposes like biopsy and degestenting removal, foreign bodies, so on. Only disadvantage is when the bladder is distended, you have to let out the contents only through the outlet here, slowly. But anyway, it is done for the quick procedures. Before bladder distends, you have to complete your procedures. That is better. Where you are using a bridge, that is, you can let out the contents very well after removing the bridge. You can decompress the bladder very quickly if you are using the sheath and bridge. So this is a very useful armamentarium for all multi-purposes endourological procedures. A word about the pediatric cystourethoscope is very important. We got a neonatal cystoscope. Wolf has made a 4.5 French neonatal integrated a compact cystoscope. So you can see here, there's offset lens. This is the bridge through which we can, it is 4.5 to 6.5 French. Through this, we can pass a Bugby electrode to manage your posterior urethral walls. And also sometimes you can also incise ureterocele and all that. So this is the pediatric scopes. And we have got also the resectoscopes. There's 2 kinds of working elements. The resectoscope sheath has got a different working element because the hole inside which takes the loop is below, is inferior. Where you can use as an erythrotome, the working element is different. The hole is above, and which takes the knife. So this can be used both 8.5 and 9.5. Sometimes the posterior urethral walls are very thick and muscular. In those cases, you have to resect actually. You have to resect this with a resectoscope, the posterior urethral walls. This is the setup, of course, with the camera attached, and that is how we go. The light cable is attached and all the irrigation. That is the setup where we have. And coming to the accessories for the pediatric scope, there is a knife, that is a VIU knife. Sometimes post-PEV fulguration may form a stricture. In those cases, we can manage with this pediatric erythrotome. And also this is a small loop, and this is a hook. So with this also, we can manage the posterior urethral walls. And sometimes you can, when there are thin leaflets, posterior through walls, you can use a Bugby electrode and just to fulgurate to touch the posterior through walls. These are 3 French Bugby electrodes. These are the various accessories which we can use it. There is an optical biopsy, both there is a flexible as well as rigid accessories are available, which can go with various cystoscopic sheets. Here you can see optical biopsy forceps and also the optical biopsy forceps and the optical grasping forceps to remove the foreign body or to remove the DJ stent and so on. We can do this. And there are adapters, very interesting. This adapter one I am having. Suppose you are doing a transurethral resection of the prostate, you want to take a bladder mucosal biopsy, you need not remove it and put a cystourethoscope. There's an adapter which you can put to this and apply introduce your cystoscopic biopsy forceps. So these are the adapters available for resectoscope as well as nephroscope. And this is the metotomy scissors, which is a 5 French flexible one. Go to the 20 French and see that this is the scissors. This is useful to cut some of the sutures inside, because once I need to cut a suture inside, because in a transplant patient, a stone is formed on the suture. So I can cut this with this scissors, and also sometimes ureteric metotomy. Some of the cases where there is a stone stuck in the lower part portion, just peeping through the meatus, you can make a cut and just deliver the stone. So those are the uses of these things. Coming to flexible cystoscope, there are 2 kinds of this fiber optic and also digital. The digital works on the principle of CCD camera. That is the chip on the tip technology. There are 2 kinds of technology. One is the CCD sensors, another is CMOS circuits. These are the 2 things. And the advantage of digital is the image resolution is good, and it doesn't require a light cable, or it doesn't require a lamp. This is directly connected to the video scope where this can be used. Of course, the fiber optics is like this. You can see here, the end of this, there are 2 fiber optic bundles which transmit the light. They are incoherent bundles. And there is a fiber optic bundle here which transmits image. This is a coherent bundle, and the channel for biopsy forceps. And also there is a deflecting system here, which you can do logic and anti-logic, they name it. Logic means if you press downwards, this also will go downwards. And if you press downwards, if it goes upwards, it is anti-logic. This is mainly to negotiate the prostatic or prostatomembranous urethra, as well as high rating bladder nets. So this is all main useful for office urology, where you can do under local anesthesia, you can do a diagnostic scopy for urethral pathology or bladder pathology, or you can remove even DJ stents in the ward or in the OPD. So urethral stent, the uses are mainly urethral stent removal, surveillance, bladder and urethral cancers, evaluation of microscopic and microscopic hematuria, diagnosis of urethral and bladder neck contracture, evaluation of LEDs, and female urethral diverticular, urethral and bladder fistula. This can be managed with local anesthesia. The size is around 15.5, and it has got a working channel of 6 French. Of course, these days, a single-use flexible scopes are coming, both cystourethoscopy as well as, of course, the ureteroduodenoscopies are coming now. Coming to the another frequently used important one, that is the treatment for stricture urethra, endoscopic treatment, stricturotomy, internal stricturotomy or optical urethrotomy, where we use a Saxis optical urethrotomy. And this is a cold knife. where we use a 0-degree lens and it contains a working element. This is actually the passive working element, thumb passive. That is what is used. This can be also used for transurethral resection. So you guys, some of you practice tomorrow, start practicing, you can buy only this working element, which is thumb passive, where you can use for optical erythrotomy as well as transurethral resection of the prostate. So this is the erythrotome. You can see the blunt end here. So it needs, when you want to introduce into the urethra, you need a trocar, obturator is a bulbous, which has got a bulbous end which comes out smoothly. So once you introduce inside, then of course you introduce working element with the lens and the knife. And there is a half moon sheath available, sometimes in a difficult strictures, more fibrous strictures. Yesterday we used to do a core through internal erythrotomy for obliterating strictures. So the moment the stricture is completed, but when you come back, we were unable to pass a catheter because it collapses. In those cases, we used to attach this to the erythrotome, but once you attach it, the French size increases. The size of the sheath increases to 23 French. So that disadvantage is there. Once it goes inside, remove this erythrotome, and through this half moon sheath, you can pass a 16 French Foley safely into the bladder. That is the advantage. And there is a outer sheath also available. Where there is a bleeding, you are unable to see the stricture properly, you can introduce again. This is an outer sheath which has got a inflow and outflow so that there will be a clear vision. So these are the additional things which usually we don't use, but these are useful instruments. Coming to the knife, usually this is a cord knife, which has got a straight one. This is commonly used for all strictures. And this is the half moon shape one which is used for bladder neck contraction. There's another knife which is serrated, which we used to do for core through internal erythrotomy. Of course, nobody does this. This is totally abundant now after the anastomotic erythroplasty has come into vogue. And the 0-degree lens again, that is what, because for urethral lesions, we use forward vision, and 0 degree is the one which we use. This is in a close view of the erythrotome. You can see this. The calibrated 21 French is marked here, the sheath. You can see the markings all along up to the tip, so that we can measure the stricture length. And the smaller round, 21.5, that means through this is the instrument channel. You can always pass a guide wire or ureteric catheter across the stricture into the bladder, so that you will not go out of the tract. I mean, you will not lose the tract. And for a right-handed person, it is on the left side, because you will be pushing a guide wire through the left hand. It is customized. If you ask the storage people, you are a left-hander, they will put it on the right side. So that is, this is the inflow and outflow. This is how. When the working element is, pushed this, the knife comes like that. So the movement will be upwards, and gradually we will cut the catheter stricture, and so this is the how you assemble completely. This is Oxford examination, how you assemble the erythrotome. So it has got a thumb passive working element, and you got a sheath and a 0-degree lens and erythrotome. A few points, practical points, which are usually asked in the examination. How deep you have to cut the stricture? So usually we cut gradually. The fibrous tissue will be seeing it till you get a splinter, small splinter hemorrhages. Sometimes you see a bluish color, that means you got deep in. If you cut further, you definitely get into the corporal tissue and bleeding. So when a splinter hemorrhage is started, that is where you have to stop it. Sometimes you have to cut less than more to avoid problems. And control bleeding, sometimes when you are cutting the stricture, there will be some oozing and your vision is impaired. In those cases, just remove the erythrotome and pinch the penis below the glands for 5 minutes. So the bleeding stops and again the vision will be clear. You can complete the stricturotomy. Sometimes if you cut deeply, this used to happen. I have seen one of our process when they are doing with ACMI. The knife is very strong with ACMI. I have seen a number of extravasations. So when you cut deeply, it goes and extravasates. You can see the blowing of the penis, sometimes the scrotum. So those cases, if you are still in the tract, of course, you complete your surgery and put back the catheter. If the urine is not infected, there is no need to drain this fluid because this is only saline. If you think the urine is infected, you have to drain it by giving multiple incisions. Otherwise, abscess will form. Extravasation can happen if you give a deep cut, and sometimes the blade can be broken. This used to happen when we are doing a core through urethrotomy. The number of occasions we have seen, we will be cutting the bone, pubic symphysis also, that we did not know when we are cutting it. So it breaks. Sometimes it's very difficult to retrieve. Don't go on searching for it as if you are searching for a needle in the haystack. So the other after 2-3 days, I saw the patient is passing the broken knife. That usually happens. And how to improve vision when you are cutting the stricture. So there is another technique which is actually devised by one of our colleagues. You pass a 5 French catheter, feeding tube through this by the side. So this will be acting as an outflow tract, and this can improve the vision. So if you, especially the bulbomembrane, I mean the distal bulbar or proximal bulbar strictures, when you are cutting, there is a chance that you will lose the tract. The mucosal flaps comes down and you will lose the tract. If you got, of course, a guide wire already there, well and good, you can manage. If it is not there, the only thing is inject methylene blue from the bladder and see the passage below. And then cut it. Or use a pediatric erythrotome so that you can easily get into the correct passage. Once you pass a guide wire, then you can slowly enlarge this, either ureteroscope or pediatric scope. Because the Mitchell has described the erythrotomy, stricturotomy by pediatric scope, especially if the stricture is at the bulbar, proximal bulbar urethra. For us, there is a tendency to exclude the knife right inside. So it may also cut the membranous urethra. So in those cases, go with the pediatric scope, inspect the stricture, and slowly cut only the bulbar portion. That is what the Mitchell has described that. Coming to the another, the bread and butter of the urologist, the TURP, which the examination also is asked, how you perform a TU or transurethral resection, and also how you assemble your instruments. So a little bit history. 1902, Hampton Young, cold punch prostate was used blindly. And then the Maxwell and Stern designed and named first resectoscope with a tungsten wire. Iglesias developed continuous irrigation resectoscope, that is continuous flow, CFR, is mainly by the Iglesias. That is what we use today, the conventional resectoscope, 26 French, Iglesias is Iglesias. There is a classification, of course, different sizes are there. They commonly used is 26 is the outer sheath, 24 is the inner sheath, 27, one of my professors used to have, is a large loop, round loop, and also you take for large adenomas because the chips will be larger, and 28 French black. Only thing is whether Indian urethras will accommodate or not, we have to see. Some of them accommodate these things. Depending on the beak, short, long, or oblique beak, the short and long sheaths, we have seen it. Nowadays, they are not coming, they are absolute. The present modern one is the oblique beak, short oblique beak, which is, easy to negotiate. Depending on the sheath material, is it a Teflon or MTC, that is metal Teflon ceramic. This is the one, of course, the modern receptoscopes are made up of. And depending on the irrigation, conventional or continuous, that is iglesias. The conventional one is usually a lesser receptoscope, that is the 24 French, where you have to discharge the bladder contents intermittently because there is no outward irrigation like the continuous iglesias. So these are the scopes which still the conventional also sometimes we have to use it when the urethra cannot admit the 26 French receptoscopes. So this is the standard receptoscope, 24 French. Even there is a 24, we have got a continuous flow resection today, 26, 27, and 28 French. 24 and 6 French color code is yellow and uses same loop, which is also yellow in color. And 27 and 28 color coded black uses same loop, which is brown. And 22 French integrated receptoscope for small urethra and color code is white. This is the various cystoscope available today. And this is the short beak or long beak, short beak. Optimization of the length was done to prevent mentioned drawback of long beak. See, the drawback is very cumbersome to introduce. Mainly, the long beak is used to supposedly occlude the bleeders during resection. And also it is said when you are doing a tuft of bladder tumors, this long beak holds the tuft away so that you can resect the beak base. That is what my professor used to tell. This I did not see anywhere in the literature. And the oblique beak, most modern receptoscope have this design. Depending on the material weight of the sheath, bakelite, this material was susceptible for easy breakage. And then came the Teflon. Then now the metal sheath gives good strength to sheath but conducts electricity. So the metal sheath has got a Teflon beak as a non-conductor, and inside there is a ceramic coating for heat resistance. So MTC sheaths, that is what you see here. The MTC sheath, distal portion is Teflon, which is non-conductor, and rest of the sheath is metal, which gives strength. Inner portion of beak coated ceramic, which is heat resistant and non-conductor. This is the one of the modern scopes which I am showing here. This is the outer sheath and this is the inner sheaths. The type of irrigation, of course, the conventional irrigation, as I said, does not have outer sheath, resulting in requirement of frequent emptying of the bladder. Continuous irrigation, as I said, has got an iglesias, it has got an outer sheath and inner sheath. Resection can be undertaken a continuous uninterrupted way. But many times you see that there's no equilibrium between the inflow and outflow. This also, you have to intermittently, you have to discharge the blood content, bladder contents. So this works on two principles of two concentric sheaths. The outflow passes between two concentrically arranged sheaths to exit tab. Advantages: continuous irrigation, avoids any buildup of pressure inside the bladder. So not only that, once the bladder is pressure is built up, the vision will be lost, and also there is a chance for more absorption of the fluid. Keeps field clear, quickens procedure of transurethral resection, maintains volume of bladder at a constant capacity for all, which is important for TURP, that is bladder tumor resections. This is how it works. This is the conventional 24 sheath. It is only got inflow. And this is the iglesias. It has got an outer sheath and an inner sheath 24. The outer sheath is 26 French. The inner is 24. So this is how the flow comes inflow through the 24 sheaths, come into the bladder and enters to, you can see this serrated outer sheath. It enters like this and goes out. So that is how it works. Coming to the obturator is one which facilitates smooth introduction of sheath. There are three types. One is viewing obturator, squeaks. This is, of course, now everybody uses. I think every theater armamentarium has got it. It is better to introduce a sheath of 26 size under vision to prevent any mishaps, urethral injury, or prostate avulsion and all that. There is a straight descending obturator, and this also snugly fits at the vesicle end so that it won't injure while introducing. It is blindly introduced, and you can see the timber leg, the deflecting one. Once the deflection is necessary at the external meatus to pass the navicular fossa, then the deflection is necessary at bulbohumerus junction. This timber leg is used. And these are the visual obturator. In bipolar, you can introduce this one. And this is the visualizing obturator, very useful for conventional, for Iglesia sheath, we use this. Coming to the working element, the thumb-operated Nesbitt system, I showed you passive. Spring retracts loop into the sheath. So in resting phase, the loop will be inside. So when you want to cut it, activate it, you have to extend. The thumb is pushed forward and the loop will comes out of it, extrudes from the sheath. So this implies that cutting of tissue is by passive retraction of spring and end stem passive. In resting state, the loop is inside the sheath, as I said. Finger operated system is the active, that means finger active. Spring extends loop out of the sheath. Cutting is eschewed by manual retraction of loop into the sheath. So when it is in rest, the loop is outside. Most of us are not trained with this. This one should be very careful. While introducing, you have to actually retract it inside and then introduce it. Inadvertently, sometimes it comes out and you may activate the cautery and cause bladder injury also. So this is, unless you are trained from the beginning, it is a little bit risky to use this. At resting, the loop remains outside the sheath. So the preference of loop to be used is a matter of surgeons, of course. This is the working element. This is finger active. This is where it is pulled like this. So that, what are the advantages? So you can see this Iglesia system. This is finger operated. This is thumb passive. This is for the thumb operated working elements for bipolar. Thumb operated, and this is finger active. These are the things. So what are the advantages and disadvantages of the active element? Advantage, movement is active, resection is supposed to be fast. That is the finger active. Disadvantages, as you said, as loop remains outside the sheath in resting phase, surgeon will be careful while operating. Inadvertently, you should not injure while activate your current while it is touching the bladder wall or something. Since cutting is active, surgeon exerts more pressure. So you have to, with a finger, you have to actively cut this prostate. So there's a chance for you may cut deeply into the prostate. That can happen. Passive element advantages: in resting position, loop remains inside, hence inadvertent damage to bladder is avoided. If foot pedal is inadvertently pressed by a surgeon or assistant, disadvantage: since cutting is passive, resection is slightly slower because you have to extrude the loop and again pull inside. So the resection is usually slow. Since cutting is passive, chips are cut in a controlled fashion. Cutting loops, of course, made of fine tungsten wire. Classification is depending on the size, 24 French and 27. Depending on the color coding, yellow 24, brown is 27. Depending on the size of the wire stranded, thick and thin. So the standard one is 0.35 mm. That is the yellow loop which we use. And thin loops are 0.25 mm. Thick loop, which I think Boston Scientific make these thick loops. When you are tackling with a large adenomas, 100 grams, you can take bulk of the large chips. You can debulk it first, initially quickly. There will be less bleeding. And because you will be using almost the high current, high frequency current will be using almost double. So later you can use a normal standard loop for the rest of the resection. That is how you can take the advantage of the thick loop. Thin loop is said for mainly bladder tumors and also when you are managing the apical lobes. You can use this thin loop. Depending on the telescope use, 0 degree and 30 degrees, of course. This is the main technology of the monopolar technology. The electric high frequency current to the loop. We are using non-conducting irrigant like water or glycine. These are the non-conducting irrigants which use. So the current goes through the tissues and passes on to the indifferent electrode. We can see that. And the resection is by vaporization. This is the monopolar. And types of loops, as I already mentioned here. Here, the standard cutting loop, which I showed you. And Collins knife, this is a useful one. So when you are doing a resection, you have to keep a standard cutting loop, a Collins knife, and sometimes the roller bar. These are the important things. In a gland, 40 grams or 30 grams, which is obstructing. If you are resecting, probably we have to add a bladder neck incisions to prevent bladder neck contracture. In that case, you have to use the Collins knife. Where there is a oozing, or you can use the roller ball. And also, the other things are conical electrode for point coagulation, blunt curettage or sharp curettage. When the bladder tumor necrotic material is there, you can curettage. And moving loop, this is mainly a bladder tumor situated on the dome. You can easily manage with this loop. These are the standard loop, this yellow color, you can see that. And one is the active element, another is the passive. And this is the Collins knife and roller ball. These are the common things which we use during a transurethral resection. So problems in loop angles. A loop angle should be, actually this is 90 degrees, still it is in correspondence to the beak or the 30-degree lens, a little bit in a 30-degree fashion. It should not be like this because the chip will not be released when you are cutting it. There will be tags. So you have to check it, and always when you start your resection, look at the loop, how it is. The angle should be properly is there in line with the 30-degree lens. And there are some precautions when you are inserting the loop. This is the lens passage site. So there is a knob here which is, and when you push this, hold this here so that the loop will not be injured, push into this slot, and once it is home, there will be a click noise. That means it is safely inside. But when you are removing, press it always. Without pressing, don't pull it. Sometimes you may spoil the loop. Those are the some of the tips to protect the loop. And router supravivic set. See, when you are using a conventional resectoscope 24 French, because all ureters may not admit the 26 French iglesias. So in those cases, you have to take a inner sheath that is 24, and you can continue resection. The problem is, if you are managing a large adenoma, you have to intermittently evacuate the bladder contents. So it gives trouble. So in those cases, there is a router supravivic triangular. You distend the bladder, put this cannula, it is about 10 French, which gives you as a good outlet and maintains the low pressures in the bladder so that you can resect fast. This is one of the useful armamentarium. You can keep it when you are resecting with the 24 French intermittent, the conventional irrigation resectoscope sheaths. And even in bipolar resectoscope, the inner sheath you can use when the urethra is not admitting or tightly fitting, because if you use this, it may land up in stricture. So take the inner sheath, but the problem is here, there is a hole here. Through this, there is escape of fluid. You cannot use alone. In a similar way, the rotating resectoscope, you can't use the inner sheath because the fluid escapes from the inner sheath through this hole, irrigating. So for bipolar resectoscope, there is an adapter available which can close this hole, and there is an inlet and outlet. This can be used with a 24 French resectoscope safely. Ischemic metatome, you have Saxis urethrotomy, you have heard. There is a metatome also. So many of the urethras may not admit sometimes the 26 French resectoscope, even 24. In those cases, you know that we'll be doing a metotomy with the scissors or a 15 blade. There is a metatome available. This is the metatome where you can calibrate what amount of metatome you need. Here, usually we use the 26 French resectoscope. So up to 28, you can keep this knife. And once you introduce up to the navicular fossa and draw it, it will make a metotomy. So that you can easily introduce the resectoscope where the excretion will be more free. I have been using this. I have tried to see a metal stenosis in my resections for the last 20 years. There's another one which is Otis erythrotome. This, some of my colleagues, they use it mainly for urethral distension. What I use is the calibration. I use the 24, 26, and 28 metal buoys. So it is a calibration, not a dilatation. Remember, when you pass these dilators, they should go into the urethra on their own, on the weight. So this is only calibration. We should not forcibly dilate it. That is the most important. Then this is used by some of our colleagues. This is Otis erythrotome. To pass it, at least the urethral size should be more than 16 French. If you closely study this, so there is a knife here, which we can put it into the groove. And there is also a calibrating disc, and there is a rotating disc. If you rotate the disc, you can calibrate 20 French, 25, up to 30 if you want. So the knife is introduced here through this groove into there is a groove on the shaft. So the knife will goes into this. And also there is a calibrated, graduated markings here. So if you look at these markings, so start from here. Then if you look at the tip is very smooth. There is a conical screw here. You can unscrew and remove it. There will be another knob with screws, which will be connected to a filiform bougie. Actually, a filiform bougie can be connected at the tip. Remove this and connect here, which can guide you into the bladder. So this knife is introduced here. When you pull this knife and this, suppose you dilate it up to 25 or 28 and pull this knife, it cuts a superficial cut of the mucosa. It won't be the cut in the dorsal aspect more than 3 to 5 mm, and at the same time, it distends the urethra. So some people say that they want to use from the bulbar urethra, but I think you can start cutting from the bladder neck because the knife surfaces only after 4 or 5 centimeters. It comes to surface. You can see here. Only it start coming after 5, 6 centimeters. Then it becomes prominent afterwards. So it mainly cuts the bulbar. It won't cut the membranous urethra. And so this is mainly for dilatation and stretching of the urethra so that the 26 French resectoscope can be accommodated easily and the exclusion will be free. And coming to the helix evacuator, we've got different evacuators. This is the 2 syringe and modified helix. This is acts by Venturi effect. You can read the physics of Venturi effect because it draws the water and the chips will reach the bottom. But when you push again water inside, the chips will not go. So this is the helix evacuator and this is the 2 I advise to buy a 50 cc 2 not 100 cc. It is very easy to handle it. 100 cc is not possible to handle it when you fall on the floor. So the 2 is very effective when you are drawing the clots, when evacuating the clots, very effective. So either can be used and it seems these causes less pressure, very surprising. It appears when you are evacuating, the fluid causes less pressure in the bladder than the 2. That is what is given in the literature. Irrigating fluids for monopolar, of course, the glycine, 1.5%, sterile water. These are the 2 important things. Of course, this is already abundant. When we were students, my process used to have this sterile water, and we used to see a number of TURP syndromes in larger glands. But now we don't see many with the glycine. Of course, glycine toxicity also can happen, especially the visual disturbances can happen with glycine. So TURP syndrome, hyponatremia may not be there, but the visual problems can be there with glycine. Coming to the bipolar, it has 2 active electrodes attached to a single supporting system. Use plasma arc for resection of tissue. The plasma arc is the one which heats up the loop and cuts through the adenoma. And the current passes through the normal saline to the indifferent electrode, which is situated in the same loop. That means the both indifferent or neutral electrode as well as active electrode are situated in the loop itself or the current may go even into the receptoscope. That is how this is works. Plasma is partially ionized gas containing free electrons, and it is conductive. This is the bipolar technology, high frequency current. If you see the settings, almost we keep the double the monopolar settings. Of course, active electrode in blue, conducting irrigant, that is normal saline, which is electrolyte conducting solution, which is ionized and forms the plasma, which you see the yellowish arc, and it passes through the tissue and cuts through this one. So the current will go to indifferent electrode in the loop itself. That is how it works. So the current will not pass through the body as it happens in the monopolar. Of course, irrigation in the bipolar TURP is the normal saline. There is no risk for TUR syndrome. TUR syndrome, in a sense, the fluid absorption will be there always. So a patient who has got a cardiac compromise, we should be careful. And resection time should be limited to patients with comorbidities. But there won't be any hyponatremia and other things. So absolutely, so that you can do a prolonged resection and large adenomas can be tackled with this, because there's no hyponatremia and its possible side effects. Advantages: less conductive trauma, so lower rate of bladder neck stenosis and urethral strictures. Because it is said in monopolar, there will be eddy currents passing through the loop, receptoscope, which can heat up and cause some urethral strictures. That is what the people say. So one of the causes for strictures. Elimination of TUR syndrome, lower risk of capsular perforation as there is no decrease in the current, stimulation of the pelvic floor, better visual orientation by reduced coagulation, and self-clearing of loop by high energy. See, when the loop, when the chip is get attached to the loop, we have to remove in monopolar. Here, there is a self-cleaning technique is there with the plasma. Limitations of bipolar technology, higher risk of conductive trauma if current is deviated via the sheath. If the current is passing through, because a proper lubricant is not there, then the chances for a stricture is there, bladder neck contracture or stricture urethra. Risk of recurrent bleeding due to small coagulated zone, that is also described. So there are different companies are providing different loops for the bipolar. The quasi-bipolar, example, Olympus tourist system. This is actually the real plasma, what they say. And plasmic kinetic resection loop gyrus and cold storage bipolar resection loop. So there are different loops. If you can look at this, this is the Olympus, where the active current passes and the current path goes to the neutral, the receptoscope sheath. But the current which goes is very little, what they say. So that's why it won't cause any strictures or bladder neck contractions. That is what you see. This is quasi bipolar and gyrus loop. If you see that, this is the active electrode and this is the neutral. It passes to the neutral through the working element. And in stars, there is another neutral electrode is arranged on the working element itself. So these are the different electrodes, and these are the bipolar working elements. This is active, thumb active, finger active working element, and this is thumb passive. And when you are introducing, one caution is when you're introducing the lens, take the support of your hand or thumb so that the eyepiece, that means the objective end, will not hit any place and damage the lens. And when you are introducing the loop, hold this where this is the metal tube for the lens. Hold it here and push it inside. Once it is home, there will be a click noise. But when you are removing, press this button and remove it. Otherwise, if you just pull, you may damage the loop. You know, the cost is very high, about 4,000 to 5,000 rupees. So you should take care of these loops in this fashion. Some do's and don'ts about the cables. This is the light cable. So you should not bend more than 60 degrees. The fiber optic fibers will break. So you have to take care of this. And usually this is heavy. And for pediatric cases, there are lighter cables are available. When you are not using it, when you are in between evacuating the bladder and all that, this should never be on the drapes, because erroneously it is called a code lamp, but definitely it burns not only the drapes but also underneath the skin. So you have to hang it on to the side so that it won't come in contact with the drapes. This is how you have to arrange your trolley for TUR or TURBT. If you have got a large trolley, so one side the blunt instruments, or if you have got two trolleys, small one, in one trolley, keep these dilators 24, 26, and 28. For a female, of course, you have to keep the Hagars and other things like the bladder evacuator and other things here. And more delicate things like high frequency cord and the cystoscopic lens here, sheath and the bridge, and also resectoscope, the lens and other things in another trolley, so that this won't come and fall on these things and damage your scopes, which are very costly. Some useful tips for safe TURP. Resectoscope parts should be inspected and made sure in working condition. As I told you, once we introduced it, when we start resection, the beak fell into the bladder. Or there will be a broken loop. So we have to check it carefully before introducing. Initial cystoscopy is very important, not only to prevent to see the urethral stricture, to avoid or to exclude urethral strictures, because one of our colleagues is a senior man, just introduced with a Timberlake obturator, and unfortunately the patient has got a stricture. So he hit the stricture, there is a false passage and bleeding, we have to abandon it. So initial cystoscopy is very important. And also, you can see the configuration of the adenoma, whether it is the anteroposterior diameter is high, or the anteroposterior or superior-inferior high, where the adenoma is maximum, is on the sides or in the floor. And also you have to see the median lobe, how far it is projecting into the bladder, and what is the relationship with ureteric orifices. So all these things I can study with a cystoscope easily, with a small cystoscope, small caliber cystoscope, and also know the bladder pathology, any stones or any tumors or any biopsies you have to take, and all these things can be planned. And then plan depending on the morphology or configuration of the gland, plan you are making, resection. Whether you follow the 6 o'clock Roger Burns technique or the Nesbitt dorsal technique, it all depends how your training goes on or what method you have adopted, which appears to be more convenient to you. Go methodically. Once one lobe is completed, resection of the contralateral lobe undertaken. Don't do here and there in this lobe and other lobe a few chips, because you will end up in bleeding on both sides and the vision will be impaired. So go methodically after one lobe after another. If you one lobe you have completed, suppose there is some problem, there is hypotension and all that, you can abandon the procedure. Sometimes with one lobe resection, patient can pass urine. You can get rid of the catheter. you can plan after some time. Or there are people who pass urine comfortably with one lobe resection. So go methodically. And coming to the arterial bleeding, you have to do a point coagulation. If you reach the capsule and there is an arterial bleeding, you can see the mouth of the ureter, mouth of the spurter. So when you see the spurter, keep your loop on that and cause tamponade, it stops. Then activate the current. Haphazard coagulation, you should not do. This causes more charring and also necrosis of the prostatic tissue, which can lead to, at a later date, for secondary bleeding. And resect up to the capsule. See, sometimes you may find oozing continuously, but you don't need any spurter. Then you check it whether you have done the complete resection. Once you complete your resection, the effluent will be clear. That is one of the important pointers here. And ricochet bleeding, that is where the bleeding will be in 5 o'clock, but this is seen, you see that it is coming on the 11 o'clock because of this pumping artery on the opposite wall. So this you have to carefully analyze and coagulate the bleeder. And sometimes the bleeder is directly pumping onto the lens. So you can't see anything. In those cases, you slowly advance the resectoscopic sheath and first stop the bleeding by applying the pressure. And slowly change your angle and come slowly back and look for the bleeder. See, these are some of the points. And about the venous bleeding, usually when there is when you open a sinus, there is a dark blood, but it disappears when you go nearby due to the outflow. That means inflow, a fast inflow. So you have to stop and see whether it is a venous sinus is open. And in those cases, you can try with a ball electrode, try to coagulate both the walls together. Sometimes, if you are lucky, you can stop the bleeding. And if it is not, and you are at the end of the resection, I mean, you don't look at this more frequently, because more frequently you look at that, there will be fluid absorption. That is one of the dangers. So quickly complete your apical resection or something and put a catheter and come out, the catheter traction. The traction will definitely help to reduce the bleeding, venous bleeding. And another important thing is undermining the trigone. This happens when you remove more and more tissue in 6 o'clock. So this can also give rise to a problem. And when you are excluding the Cystoscope in and out, it will further damage the trigone. So there will be difficulty in passing a catheter. You may have to take other tricks by passing a catheter, police catheter, or a guide wire, or an introducer, or piggyback technique. You have to put it inside. So there's nothing, I mean, if you leave some tissue in the floor, it's not going to obstruct. So don't undermine resecting more and more tissue at 6 o'clock position. Then capsular perforation, the minor perforations usually occurs in the base. If you are seeing the glistening fat, that means you have perforated. And if you are in the middle of the resection, don't go that side, complete your resection. A large perforation, and there is an extravasation of fluid, which you can find out. Immediately the patient complains of pain, because if the fluid escapes into the retropubic space, the peritoneum will be irritated. So the patient complains of pain and start moving. So if you think there is a large amount of fluid extravasated, suprapubically, or retrovesically, you can make a small incision and drain and put a dry, corrugated rubber line. Inadvertently, if you perforate the bladder, minor perforations, no problem. If there is a the effluent is not coming out at all, there's a major perforation, I think you should open and close it in SPC. And UO injuries, this can happen when there is a intravesical projection of the median lobe. That's why when you are doing a cystoscopy, you have to identify the ureteric orifices. If you are not able to see the ureteric orifices, you start resecting in the middle of the median lobe slowly until you see the ureteric orifices. Inadvertently, if you ablate the ureteric orifice, if you are using a cutting current, there won't be any problem. If you are using a coagulating current, I think you have to put, this may end up in a stricture and hydroureteronephrosis at a later date. So you have to put a degestant in those cases. But importantly, these patients should be followed up periodically for in hydronephrosis because they go silently, death of the kidney if you don't follow them. And capsule identification. This is often asked in the examination. How do you identify the capsule that you reach? So one is, it is pink. It is described as a mosaic flow. You may not get it like that. But here and there in the capsule is definitely exposed. You can see that it's a smooth pink color. And another important thing is the corpora amylaceae, the black pepper, started coming up. This is actually at the capsular level. At the pseudocapsular level, that means you have reached the capsule. Another point is, if you stimulate with a loop, the capsule, it contracts, that you can see actually. And the timing of Lasix, usually because fluid absorption will be there, whether it is bipolar or monopolar, the minimum will be about ½ liter. Sometimes if the resection is prolonged, may go up to 2 liters. So the timing is when you're reaching the latter part of the resection, that is when you're reaching the capsule, that is where and when the fluid is absorbed. So at that time you have to ask, provided the pressures are good, you can ask the anesthesiologist to give 40 milligrams Lasix to drive out the excess fluid. So that is about the transurethral resection of the prostate. And there is another interesting thing is cystolithotripsy instruments. Before that, you should know some of the things in the examination may be asked, the nomenclature of the procedure. What is cystolithopaxy? That is intact removal, picking up a small stone in the bladder. Or cystolithotrity, that is mechanical crushing. And cystolithotripsy, that is what frequently done today, breaking of the stone with energy using a lithoplast or laser, whatever it is. And cystolithotomy, if a large stone is there, of course, you have to open and take it down. So bladder stone management, transurethral small stones, you can use mechanical crushing. There is and large stones, multiple stones, you can manage through suprapubic route using the PCNL equipment, the Ampla sheath and a nephroscope. This is one of the crushing forceps, stone crushing forceps, also named as crocodile forceps. You look at this, there are serrations. This fits into the 25 French cystoscope. You have to use a 30-degree lens, and 1 or 2 centimeters easily can be crushed in the bladder. So when you are holding the stone, don't hold the stone in the middle and try to crush it. The jaws may break. So you just bite it one corner of the stone. Slowly, slowly from the corner, you bite small chips. That is the trick here. And of course, the handle, lithotrite. We used to use when we were postgraduates. This has to be passed like a dilator. So you should know the urethral passage and dilator passage without injury. So injuries are common. You have to close it, the jaws, and then you have to pass it. Once you are inside, they use the 70-degree lens here and there is a knob here, screw, which can maintain the space between these jaws. Once you hold it firmly, then you can crush it. The important thing is while crushing, your bladder should be full and it should be in the middle of the bladder. And you are using a 70-degree lens, it is better to remove the lens and then open this, take this working element and crush the stone. That is the principle. And nowadays, of course, these things are not used because they are causing urethral injury. It happened to many people. They injured the urethra while introducing. Sometimes the jaws may be closed, may not be closed. Then it is removed. Difficult to remove. You have to open and remove the stone debris. So this another Moyle-Meyer's stone punch. This is also obsolete today. We have used it when we were assistant professors and all that at the time. Nowadays, the nephroscope, the extended length nephroscope is available from the stores, 25 centimeters, 24 French. So with that, bladder stones can be managed using lithoclasts, or in the suprapubic road, even the 19 centimeters nephroscope, 18 French also can be used. The current techniques of lithotripsy using lithoclasts, ultrasound, or shock pulse, because these are the energies which you use, of course, mainly the lithoclasts. Of course, whoever having a stone pulse, this also can be used to manage fairly 4 to 5 centimeters large stones in the bladder. And one important thing is, if you look at this, this is not uncommon today. A DJ strand forming the stone here, the lower loop in the bladder, never use these crushing elements. Because if there is a soft tissue here, the jaws get stuck and you cannot remove it. This happened to one of our colleagues, and you have to open them, cystotomy, then remove this, this debris. So never use always energy to disintegrate these stones. Never use a crushing forceps or lithotride to manage the stones. Lastly, the care, cleaning, and sterilization are very important. You have to train one of the nursing staff, or your postgraduates should be trained how to take care of these. After the end of your procedure, a thorough cleaning under the tap water. It needs a separate sink. It should be flushed all organic material. Hello? Hello, anybody? Anything?
Hello, sir.
Yeah. So this is a manual cleaning or mechanical by ultrasound mechanism. Drying and packing are very important before you sterilize them. Most of the endoscope instruments comes from the semi-critical items. So they can be managed with high-level disinfection. Most of us use the Sidex, activated glutaraldehyde. So this will take care. If you keep it for about 30 minutes, it will definitely disinfect. And if you keep for more than 10 to 12 hours overnight, it also sterilizes all the bacteria, the Sidex. And ETO is one other important thing. All your high frequency cards, working elements, or even lenses, and this can be all your thick tubings can be managed with the ETO sterilization. Of course, once you take care of this other side effects of this, you have to take care. And steroid is one of the ideal thing, because almost all endoscopic equipment can be sterilized with steroid. So what I suggest is, at the end of the day, all instruments are sterilized with steroid ones. And once you start using, in between cases, we dip in the side X for about 10 minutes or 20 minutes for the high disinfection. Of late, the OPA and Paracet are coming into this. They are very effective. They are effective more than the side X. Thank you. That is the end of my talk.
Dr. Gyanendra, over to you.
Thank you, sir. Thank you, sir, for an excellent talk. I think you have covered each and every aspect of each and every instrument that is used in the lower urinary tract. And what has been very pleasing is the tips and tricks that you have mentioned when somebody deals with difficult situations, as in TURP bleeding, and while catheterizing, and even while doing cystolithopsy. One question from my side. You mentioned that Mormaer stone punch is obsolete nowadays. Is it really? Because I have been using, it is probably my favorite instrument when it comes to dealing with bladder stone.
But you can manage only a smaller ones, is it not? About 2-3 centimeter stones.
Yes, sir. Even
Not
4
bigger one.
centimeters. What I do is a combination of lithotripsy
That is an
or
excellent.
mechanical.
That is an excellent crusher, stone crusher, because it has got a very sturdy outer sheath and a punch working element. Really, I used it. I used it. That is great. You are still means you have been using and you're an expert. Definitely, there should not be any problem. It won't cause any problem for you if you are using from the beginning. For the beginners, I think today my students also, they introduce an nephroscope and take the lithoclast and finish it. That is what they're doing because the introduction itself, they got some problems with this. Like that, the lithotrite also, because I have done many procedures with the lithotrite.
Yes, sir.
That is also very good. But they are prone for injury. So, because we have seen people getting stuck in the bladder. I got stuck once inside. So when I was crushing the stone with a lithotrite, there is inside, there is a police bulb burst latex rubber. So the rubber got stuck to the jaws and jaws cannot be closed. So I had to open it and remove all those latex rubber from the jaws, then take out the lithotrite. So this is one of the things. I think stone punch is good. I have used it.
Yes, sir. One
There's no
question
doubt
from
about it.
Kalra. What are the precautions one need to take when one uses a stone punch?
Yeah, one is the, you have to reverse it, I believe. Reverse, and bladder should be full like that for lithotrite. And you have to take out the lens and then crush it. That is what I remember when I used it. Anything you would like to add points?
Sir, I think you have mentioned it pertaining to the Hendrickson's lithotrite.
Yeah.
Yeah, which is used by using a 70-degree telescope.
Yes.
Sir, for Mormaer stone punch, I usually see to it that the bladder is distended. The jaws are in front of us. They are seen. And when you catch hold of the stone, one needs to be aware that one is not catching the bladder mucosa.
Bladder mucosa, of course.
And then crush it. So everything needs to be under vision.
Yes. It is under, so the lens will be stays there. The lens will be there.
Yes, sir. Yeah, I use it with a 30-degree telescope.
Yeah, it is in the middle of the bladder with the distended bladder. In the middle, you will keep it without touching the mucosa or bladder wall. Yes.
It is best useful if the stone is roughened. If it's a smooth,
catches, yes. It slips away. It jumps away from that. Nice.
Another question was again something which is not used nowadays. that you mentioned the scissors, myectotomy scissors.
Yes.
The original scissors which came used to cut at 12 o'clock and 6 o'clock. But then
Which one? Please
the
repeat.
usual scissors which were brought by
Myectotomy scissors. Yeah.
yeah, they were opening, the jaws were opening vertically. And the subsequent scissors jaws were opening horizontally because the dictum used to be that you cut at 3 and 9 o'clock position rather than at 12 or 6 o'clock position.
Oh.
But is it really used nowadays?
No, see, the thing is that if the stone is stuck in the intramural portion and peeping out, what I do is I use the Collins knife and give the hard cut over the stone. And
Yes.
with the Collins knife, I can deliver.
Yes.
And myectotomy, usually not necessary. This myectotomy scissors cannot be used. But if you are using it, we can always cut in 12 o'clock. I did not find any problem in the cutting it to 12 o'clock. But where I used it one or twice to cut the sutures in the bladder. After transplant, the sutures are seen and there is a stone. So I have gone there up and cut the suture. So that was helpful for me during that time. But I did not find any problem in ureteric myectotomy. But while doing, you have to put some support like a ureteric catheter down as much. I think I did not find any problem in ureteric myectotomy.
Any questions from Chawla sir?
I think there's no question, but he has very excellently and comprehensively covered not only the instruments, but as well as the operative surgery part. So that was indeed a very good addition to the armamentarium. Very comprehensively covered. What I'll urge the writers is to just go in back to the video, see again, and before exams, watch again repeatedly, because the instruments should not be taken lightly. These are your lifelong treasure. You need to use them with your own hands. These are costly instruments. You need to take care of them. You need to know how to operate them, and you should know how to correctly use them. There are many occasions where residents learn the procedure without knowing the instruments. And when he goes into the practice and he's on his own, and he has to be taught by a nurse or a senior colleague how to. The same way it is for buying instruments. So all these things are very interconnected, and that's why we have kept this armamentarium class, which was in addition to the mock exam which we had in Hyderabad with Dr. P.V. Murthy, so that we can have two expert in this field covering this area. Again, I urge the resident to please watch this video again. It will be in the YouTube tomorrow in the ISU USI archives and before exam also. This because this is not only covered the instrument but the operative surgery. Many important questions which are asked are covered. And on behalf of Indian School of Urology, many thanks to Dr. Murthy. We had initial glitch of logging into that, but he actually covered it with a very erudite presentation. I think that's from my end. Over to you, Dr. Sharma.
Yeah, sir, there are no further questions also in the chat box. It has been an exhaustive coverage of every aspect of the lower tract instruments, sir. So, if there are no questions,
there is, sir, Sharma, can you take that Anuj other question? Have you taken that?
Yeah.
Whatever have come in the chat box, I have taken it.
Yeah, okay, great then, Yeah. Fine then. Thank you. With this, if Dr. Murthy, again, many thanks to you. We'll sign off, Dr. Sharma.
Yeah, thank you.
Thank you so much.
Thank you very much. Good night.
Good night. Thank you, Dr. Sharma and Sabnis and Dr. Arun Chawla. Bye. Good night.
Good night, sir.